Welcome to the IGPNEA online education series for general practice nurses. My name is Theresa Lowry Lehnen. I'm a member of the Carlow branch, and today we will be discussing the topic of atrial fibrillation. Atrial fibrillation is the most common cardiac arrhythmia diagnosed in clinical practice and affects more than 33 million people worldwide. Characterized by the rapid and irregular beating of the atrial chambers of the heart, episodes of which may become longer or continuous over time, atrial fibrillation is associated with a significant risk of transient ischemic attack, ischemic stroke, systemic embolism, and death. While not immediately life-threatening like some cardiac arrhythmias, atrial fibrillation carries a five-fold higher risk of stroke caused by the formation of blood clots in the heart and blocked blood vessels in the brain. The percentage of people with AF increases with age, with 0.1% under 50 years, 4% between 60 to 70 years, and 14% over 80 years of age being affected. Due to increased lifespan, atrial fibrillation is on the rise and predicted to affect 14 to 17 million people in Europe by 2030, with 120 to 215,000 new cases per year. In particular, 7 to 8.5 million people will be affected by permanent AF, 3.5 to 4.2 by persistent AF, and 3.5 to 4.2 by paroxysmal atrial fibrillation. A further 280 to 340,000 new ischemic strokes, 3.5 to 4 million hospitalizations for AF, and 100 to 120 million outpatient visits can also be added to these figures. AF constitutes a public health challenge with high comorbidity and increased mortality risk and is a significant cause of increasing healthcare costs globally. An estimated 1.4% of all adults over 65 years living with undiagnosed atrial fibrillation means more cases of unmanaged atrial fibrillation will create even further economic strain on our healthcare systems. Atrial fibrillation is multifactorial in nature. Abnormalities or damage to the heart structure are the most common causes. Atrial fibrillation is more common with increased age and affects certain groups of people more than others. While it can sometimes affect people who are physically very fit, AF is more common in people with other heart conditions such as hypertension, atherosclerosis, cardiomyopathy, pericarditis, heart valve, and congenital heart disease. A family history of AF may also increase the risk. AF is also associated with other medical conditions such as pneumonia, lung cancer, pulmonary embolism, sarcoidosis, obstructive sleep apnea, hyperthyroidism, and obesity. A number of triggers are associated with the condition, including smoking, excessive alcohol, and/or coffee consumption. When no other medical conditions are associated with it, it is called lone atrial fibrillation. Atrial fibrillation is often asymptomatic, especially in the elderly, but many patients experience palpitations, rapid and irregular heartbeat, vague chest discomfort, or symptoms of heart failure such as weakness, lightheadedness, and dyspnea, particularly when the ventricular rate is very rapid. Patients may also present with signs and symptoms of acute CVA or other organ damage due to systemic emboli. Diagnostic investigations of atrial fibrillation typically includes a complete medical history and physical examination, ECG, full blood count, urea and electrolytes, and serum thyroid stimulating hormone level. All patients who present with symptoms of AF should have at minimum their pulse checked for irregularities as well as a 12-lead ECG. Other diagnostic tests for atrial fibrillation include chest X-ray and echocardiogram. Echocardiography is carried out to assess for structural heart defects, such as left atrial enlargement, left ventricular wall motion abnormalities suggesting past or present ischemia, valvular disorders and cardiomyopathy, and to identify additional risk factors for stroke, such as atrial blood stasis, thrombus, or complex aortic plaque. Atrial thrombi are most likely in the atrial appendages, where they are best detected by transesophageal rather than transthoracic echocardiography. ECG findings for AF indicate the absence of P waves, irregularly irregular RR intervals, and the presence of F or fibrillatory waves between the QRS complexes. Fibrillatory waves are irregular in timing and morphology, with baseline undulations at rates up to or greater than 300 beats per minute, best seen in lead V1 and not always apparent in all leads. Atrial fibrillation is a progressive disorder. The exact electropathological mechanisms underlying persistence of AF are at present unknown, and none of the available recording techniques can determine the degree and extensiveness of atrial electropathology or determine the stage of the condition at any time in the process. Identifying individuals at risk of developing atrial fibrillation is important, however, as there is strong evidence that early detection and treatment of modifiable risk factors can reduce morbidity and mortality. The European Society of Cardiology distinguishes 5 types of AF based on presentation and duration of arrhythmia. First diagnosed AF is every patient who presents with atrial fibrillation for the first time, irrespective of the duration or the presence and severity of AF-related symptoms. Paroxysmal AF that terminates spontaneously, usually within 48 hours, although AF paroxysms may continue for up to 7 days. After 48 hours, spontaneous conversion is low and anticoagulation must be considered. Persistent AF, that's continuous AF, sustained for more than 7 days, or requires termination by cardioversion, either with medications or by direct current cardioversion. Long-standing persistent AF, that is continuous AF of greater than 12 months duration. It is usually decided to adopt a rhythm control strategy at this stage, and permanent AF is said to exist when the presence of the arrhythmia is accepted by the patient and physician. Rhythm control interventions, by definition, are not pursued in patients with permanent AF. Should a rhythm control strategy be adopted, the arrhythmia is reclassified as long-standing persistent atrial fibrillation. The absence of atrial contractions in atrial fibrillation predisposes the patient to thrombus formation. Risk of stroke is higher in older patients and in those with mechanical heart valves, rheumatic valvular disease, hyperthyroidism, hypertension, diabetes, left ventricular systolic dysfunction, or previous thromboembolic events. Systemic emboli can also cause malfunction or necrosis of other organs. Atrial fibrillation may impair cardiac output. Loss of atrial contraction can lower cardiac output at normal heart rate by about 10%. Such a decrease is usually well tolerated except when the ventricular rate becomes too fast, greater than 140 beats per minute, or when patients already have borderline or low cardiac output. In such cases, cardiac failure may develop. Treatment of atrial fibrillation varies from person to person and depends on the type of atrial fibrillation, symptoms, treatment of any underlying cause, age, and overall health. The first step is to try to find the cause of the atrial fibrillation. For example, hyperthyroidism can sometimes be the underlying cause, and medications to control the condition can correct the symptoms of atrial fibrillation. If no underlying cause is found, treatment of AF is usually aimed at either rhythm or rate control. Since AF induces electrical, structural, and contractile remodeling, therapy aimed at prevention or restoration of remodeling and consequently restoration of sinus rhythm should be the first choice strategy. The different AF treatment modalities include pharmacological therapy, electrical cardioversion, pacemaker implantation combined with His bundle ablation, or surgical isolation of the pulmonary veins with or without additional linear lesion substrate modification. Antiarrhythmic medication can control atrial fibrillation by restoring normal heart rhythm and controlling the rate at which the heart beats. The choice of antiarrhythmic depends on the type of atrial fibrillation, comorbidities, side effects of the medicine chosen, and response to therapy. Some patients may need more than one antiarrhythmic to control atrial fibrillation, and a variety of medications are available to restore normal heart rhythm. The aim is to reduce the resting heart rate to less than 90 beats per minute. However, in some people, the target is less than 110 beats per minute. First-line drugs include beta blockers such as propranolol or atenolol, and non-hydropyridine calcium channel blockers such as diltiazem or verapamil, which slows the conduction of impulses to the ventricles. Digoxin may be added to control the heart rate further. Digoxin is usually only effective for controlling the ventricular rate at rest and should therefore only be used as a monotherapy in predominantly sedentary patients. Antiarrhythmic drugs can be classified clinically into those that act on supraventricular arrhythmias, example verapamil, both supraventricular and ventricular arrhythmias, example amiodarone, and those that act on ventricular arrhythmias, example lidocaine. They can also be classified according to their effect on the electrical behavior of myocardial cells during activity. This is the Vaughan-Williams classification scale. Class 1 antiarrhythmic medications are membrane stabilizing drugs, example lidocaine and flecainide. Class 2 are beta blockers. Class 3 include amiodarone and sotalol, and Class 4 are calcium channel blockers, including verapamil, but not dihydropyridines. The negative inotropic effect of antiarrhythmic drugs tends to be additive. Special care should be taken if two or more are used, especially if myocardial function is impaired. Many medications that are effective in countering arrhythmias can also provoke them in some instances. Patients must be monitored closely as common side effects of antiarrhythmic medications include hypotension, fatigue, nausea, vomiting, possible issues with liver, kidney, thyroid or lung, and heart rhythm disorders. Amiodarone causes sensitivity to sunlight and skin changes are common. Therefore, sun protection is important when taking this medication. Aspirin is not recommended to prevent strokes caused by atrial fibrillation. Patients with a high or moderate level of risk of stroke or thrombus formation due to atrial fibrillation are usually prescribed an anticoagulant such as warfarin or a newer type of anticoagulant, novel oral anticoagulants NOACs, also called direct oral anticoagulants such as dabigatran, rivaroxaban, apixaban, or edoxaban. There are fewer dietary and medication interactions with the newer agents and less need for monitoring. NOACs are at least as effective or superior to warfarin for stroke prevention in patients with non-valvular atrial fibrillation and are at least as safe as or safer in terms of bleeding risk according to 3 large clinical trials. NOACs have major pharmacological advantages over warfarin, which is a vitamin K antagonist, including rapid onset offset of action, few drug interactions, and predictable pharmacokinetics. Practical advantages of novel oral anticoagulants over warfarin include fixed once or twice daily oral dosing without the need for coagulation monitoring. Potential drawbacks include a risk of bleeding that might be increased in patients over 75 years of age, the lack of a routine laboratory test to reliably measure anticoagulant effect, and previously the lack of an antidote for reversal. Choice of NOAC is influenced by the patient's individual characteristics, including risk of stroke or VTE, risk of bleeding and comorbidity, in particular renal dysfunction. It is also recommended that one of the bleeding risk scores, such as the HAS-BLED score, be used to help risk assess patients. The choice of agent should take into consideration the patient's age, weight, and creatinine clearance, as dose adjustment may be required. Cardioversion is a medical procedure carried out in a hospital setting by which a tachycardia or other cardiac arrhythmia is converted to a normal sinus rhythm using an electric current or pharmacology. Synchronized electrical cardioversion uses a therapeutic dose of electric current to the heart at a specific moment in the cardiac cycle, restoring the activity of the electrical conduction system of the heart. Electrical cardioversion has success rates between 65 to 90% and can be performed safely as a day case procedure. The likelihood of success can be further improved by the co-administration of antiarrhythmic drug therapy. Pharmacological cardioversion, also referred to as chemical cardioversion, uses antiarrhythmic medication instead of an electrical shock. Pharmacological cardioversion is often used for the treatment of atrial fibrillation of recent onset. Flecainide, albuterol, propafenone, and vernacalant can be used in patients with no structural heart disease. Where structural heart disease is present, intravenous amiodarone is the drug of choice. Flecainide, administered intravenously in patients with AF of recent onset, has been shown to restore sinus rhythm in up to 95% of patients, with greatest success rates in those who receive treatment within 24 hours of atrial fibrillation onset. When AF has persisted for greater than 48 hours, pharmacological cardioversion is much less likely to be effective. Amiodarone appears to be the most effective agent for restoring sinus rhythm in patients with persistent atrial fibrillation. For patients who have been in AF for longer than 12 to 24 hours, or in whom the duration of the arrhythmia is not clear, a minimum period of anticoagulation of 3 weeks is recommended before cardioversion. Even if echocardiography has demonstrated no thrombus before cardioversion, patients should be anticoagulated for at least 1 month post-cardioversion, since mechanical atrial function may return slowly after cardioversion. Catheter ablation is performed by a cardiac doctor who specializes in heart rhythm and is an option if medical treatment for atrial fibrillation has not been successful. The procedure restores the heart's normal rhythm by electrically isolating the left atrium from the pulmonary veins, where most abnormal electrical activity that promotes atrial fibrillation originates. The procedure destroys or ablates the diseased area of the heart and interrupts abnormal electrical circuits. The principal reason to place a pacemaker in a patient with atrial fibrillation is to treat symptomatic bradycardia, especially due to sick sinus syndrome. This tends to be mainly used in people over 80 years of age. Atrial flutter is much less common than atrial fibrillation, and its causes and hemodynamic consequences are similar. About a third of people with atrial flutter also have atrial fibrillation. Both conditions carry increased risk of stroke. In atrial fibrillation, the atria beat irregularly. In atrial flutter, the atria beat regularly but faster than usual and more often than the ventricles, and there may be 4 atrial beats to every 1 ventricular beat. During atrial flutter, unlike atrial fibrillation, electrical activity in the atria is coordinated. The atria do contract, but at a very rapid rate of 250 to 350 beats per minute. This rate is too fast to allow every impulse to be conducted through the atrioventricular node to the ventricles. Because the AV node cannot usually conduct at this rate, typically half of the impulses get through, resulting in a regular ventricular rate of 150 beats per minute. The diagnosis of atrial flutter is by electrocardiography. In typical flutter, ECG shows continuous and regular atrial activation with a sawtooth pattern, most obvious in leads 2, 3, and AVF. Carotid sinus massage can increase AV block and better expose the typical flutter waves. A similar response may follow pharmacological AV nodal blockade, example with adenosine, but such therapy does not terminate atrial flutter. Treatment of atrial flutter focuses on ventricular rate control, rhythm control, and prevention of thromboembolism. Patients with chronic or recurrent atrial flutter require an oral anticoagulant. The choice among the therapies is based on the same consideration as that for atrial fibrillation. Patients often require cardioversion or atrial flutter substrate ablation. Atrial fibrillation is the most common cardiac arrhythmia, affecting at least 3% of Irish adults over 60 and is associated with almost 1 in 3 strokes in Ireland. Globally, the prevalence of AF is rising, and approximately 600 men and 375 women per 100,000 population are affected. In the 2017 report, Burden of Stroke in Europe, the Stroke Alliance for Europe signalled a possible 58% increase in the absolute number of strokes in Ireland over the next decade. Much of this can be accounted for by increasing numbers of AF-related stroke as our population ages. The population aged 65 and over in Ireland is increasing at the rate of 4% annually. The CSO predict that over 65s will represent between 21.5 to 27.9% of the Irish population by 2046. As a result, AF is a growing public health concern. Projections show that the number of people living with a stroke as a chronic condition will rise from 3,718,785 in 2015 to 4,631,050 in 2035, representing an increase of 25% or almost 1 million people across Europe. There are approximately 8,000 strokes in Ireland annually, a third of which are associated with atrial fibrillation. In 2015, HICWA published a health technology assessment of a national screening programme for atrial fibrillation in primary care. The HTA announced that a national screening programme for atrial fibrillation for over 65s in primary care would be cost effective. Analysis estimated that screening would result in the detection of 1 additional atrial fibrillation case for every 22 people screened from age 65 onwards and 1 stroke avoided for every 270 people screened over the same period. The total incremental cost to the HSE was estimated at 3.7 million over the first 5 years. This included the additional cost associated with screening. ECGs and atrial fibrillation drug therapy in diagnosed cases, as well as the cost savings resulting from a gradual decrease in stroke incidence over a period of 5 years. Almost 11% of Irish adults aged 65 years and over attending general practice have atrial fibrillation. The HSE 2015 study, Atrial Fibrillation Screening in General Practice, concluded that opportunistic screening for an irregular pulse in general practice to assist in the detection of AF is both feasible and beneficial. This multi-site prospective observational study found that approximately 8,415 new cases of AF could be identified by opportunistic screening in general practice each year. Each GP could expect to diagnose 17 new cases per 1,000 patients annually through opportunistic screening in practice. General practices are well placed to opportunistically screen older patients and are ideal in terms of the pathway for treatments of those identified. Opportunistic screening for an irregular pulse carried out by general practitioners and general practice nurses has the potential to be an extremely important stroke prevention strategy capable of saving society and the health service significant social and economic costs. General practice nurses play an essential part in the delivery of quality primary care and have a growing responsibility in the screening, assessment, treatment and management of conditions including atrial fibrillation. We provide a holistic person-centered approach with ongoing assessment, management, support and education. Key roles are to establish a therapeutic relationship with the patient, assessing their understanding of the condition, establish goals and expectations for successful management of their condition, and evaluate the physical, emotional, and psychological effects on their well-being. Many nurses can perform diagnostic examinations, prescribe medications, and other types of treatment independently or in conjunction with a doctor. We provide communication, advocacy and counselling and are involved in quality improvement initiatives and research. By implementing person-centred care, monitoring and evaluating symptoms, outcomes and responses to therapy, GPs and practice nurses play a pivotal role in managing the illness and improving the patient's quality of life. This is a list of the references that were used in the production of this presentation. I hope you enjoyed this presentation on atrial fibrillation, which is part of an online education series for general practice nurses produced by the IGPNEA. My name is Theresa Lowry Lehnen. I'm a member of the Carlow branch. Thank you for watching and listening.